Hello and welcome to the Institute for Molecular Science and Engineering's first highlight webinar of this academic year, Electronics on the Brain, presented by Professor George Malliaras from the University of Cambridge. I'm Leah, the IMSI Events Officer. So before we begin the presentation, I'm just going to run through a few top tips just to make sure that we can have a really great webinar. So please make sure that your microphone and video are switched off as an attendee. They should already be switched off, but please do just double check. If you wish to ask a question about the presentation, please put your question into the Q&A function at any time during the webinar. Your questions will be answered at the end, however. Please do not put questions about the presentation into the chat function. This should be reserved for if you have any technical difficulties. So please message IMSI Imperial privately and I will try and help you where possible. The chat function will pop up at the beginning of this presentation, but that's just a few links, including registration for all our events, the YouTube channel, and some other things which you may find interesting. So I will now hand over to Dr. Felice Teresi, who will now introduce our speaker.
Yes, thank you, Lee, and welcome to the first IMSI seminar. And I'm Felice Teresi from the Department of Chemistry, and it's a great honor to have Professor George Malliaras today talking about electronics on the brain. So a short video from George. He's a Prince Philip Professor of Technology at the University of Cambridge, and he received his PhD from the University of Groningen in the Netherlands, and then he went for a postdoc at IBM Research Center in the USA, Almaden. And before joining Cambridge, he was actually a faculty member at Cornell University, where he also was a director of the nanoscale facility over there. And then he also worked as a professor at the School of Mines in France. So his research is recognized with awards from the New York Academy of Sciences, the US National Science Foundation, and DuPont, and he also holds an honorary doctorate from the University of Linköping in Sweden. He's also a fellow of the Material Research Society and the Royal Society of Chemistry, and also serves as Deputy Editor of Science and Advances. And I'll stop here and I look forward really to his talk. Over to you, George.
Thank you, Felice, for the very kind introduction, also for inviting me. Thank you, Leah, for the organization of this seminar and the visit in general, which has been wonderful. It's a pleasure to be with you. I wish times were different and I could be there in person, but we'll make the best of it virtually. Can you see my slides and can you see my cursor?
Yeah, yes, we can.
Wonderful. Thank you. So let's start. I'll talk about electronics on the brain. I'll talk about devices that go either or in the brain and interface with it. And I will explain why we want to do this. The why is explained here. The leading cause of disability worldwide is neurological disorders. They account for over 270 million disability adjusted life years, or DALYs as known in the medical language, lost to neurological disease. These were figures from 2016, the last year where there was a comprehensive survey, and the trend was worsening. Stroke is leading the way, but migraines, dementias, and so on and so forth also constitute major causes of loss of productivity. The bad news that compounds the situation comes from the pharmaceutical industry, and is that drug discovery is becoming slower and more expensive. This is called Ehrum's law, which is Moore's law spelled backwards, where in the electronics industry things get faster and cheaper every year. In pharmaceutical industry, drug discovery slows down, as shown here. To the point where now it costs over $1 billion to deliver one new drug. So that's not gonna give the answer to the trend of neurological disorders becoming worse, a worse affliction for humanity every year. The good news comes from the field that is called bioelectronic medicine, which is a life-changing technology. And here you use electrical stimulation of the nervous system to deliver treatment. One example is in deep brain stimulation, shown here, where you implant electrodes deep in the brain in a structure, in this case called the subthalamic nucleus, to act on symptoms of Parkinson's disease or dystonia or tremor or epilepsy by just a flick of a switch. Look at this example shown here. The patient goes from not being able to hold a glass of water to having quite good degree of his arms with a flick of a switch. These devices are also being tried now for neuropsychiatric disorders such as obsessive compulsive disorder, depression, and even for conditions such as obesity. So this is really promising. And it's something that dates back to the invention of the pacemaker in the late 50s, early 60s, where you would use these devices to treat arrhythmia. Today, this is a standard operation that happens to the tune of over 600,000 implantations per year. A decade later, late 60s, early 70s, cochlear implants for restoring hearing became available. Today, again, rather common procedure, over 35,000 recipients per year. Then spinal cord stimulators for pain, vagus nerve stimulation for epilepsy, stimulators for bladder control. Then the brain became a target with deep brain stimulation for Parkinson's, for OCD, and the eye, peripheral nerves, and so on and so forth. This is not a comprehensive chart of the different stimulators out there. The trend is accelerating, and there are more and more conditions that can be treated today with FDA-approved stimulators. So good news, looks promising. What are the limitations? Why is this not more widespread today? First and foremost is we do not understand how it works. We do not understand how the brain works to begin with. It's a very complex machine consisting of over 80 billion neurons in human that are connected in fairly complex networks. And although we understand how neurons communicate with each other, we understand that the neuron can get excited, fire an action potential that travels down the axon. There are fluxes of ions, sodium going in, potassium going out of the cell membrane. Then when the action potential arrives in the synapse, you get release of neurotransmitter via exocytosis that either inhibits or excites the postsynaptic neuron. These are things we understand reasonably well. But how you go from that to behavior is something that there's a big gap there that is not understood. People are trying to do this in the clinic. For example, you have configurations of electrodes that are either placed on the scalp, where we talk about electroencephalography, or penetrate into the brain in a stereotaxic placement. We talk about depth probes, penetrating probes, or stereotaxic electroencephalography, or cortical electrodes that are placed on the surface of the cortex. So these are configurations that are used to record and even stimulate the brain. And we're trying to bridge the gap from neuronal activation and communication to behavior. Now, there are trade-offs here. These electrodes are non-invasive. They can capture activity without disturbing the brain, but their spatial resolution is very poor because you're sitting far away from the source of neural activity. Here, you can go and sit right next to the neurons that are firing. You can get excellent spatial resolution to the tune of a single neuron. However, this is invasive. Cortical arrays were thought to be in between the two in terms of this trade-off between resolution and invasiveness. They're less invasive than penetrating ones. They do not disturb the neural environment. On the other hand, they were thought to not be able to provide single neuron activity. because the neural signals that emanate at the surface of the brain are very weak, and as a result, they require a large electrode to capture them. Then how do you modulate behavior when you apply electric fields is also not known. We have devices that work in the clinic, but the mechanism of neuromodulation is not understood. Now, these fundamental, if you wish, limitations go hand in hand with technology limitations. Signals are very small. I mentioned the case of cortical electrodes that need to be large, and as a result, lose spatial resolution because the signals are small. The environment in vivo is hostile to electronics. If you have a piece of silicon in the brain, it will etch to the tune of a micron a month. And the etching will take place through oxidation and hydrolysis, and it's just a hostile environment to deal with. It's highly invasive, the implantation of electrodes, both to the brain and to the electrodes, and often multiple surgeries are required in order to place the electrodes in the right position, to replace exhausted batteries, and so on and so forth. So these limitations go hand in hand with our ability to understand the brain. So the point that I want to make is that new technologies are urgently needed to address these technological limitations and enable a better understanding of the brain and deliver bioelectronic medicine. So the points that I'll make today are three. I will talk about mixed electronic ionic conductors as a way to improve the coupling between neural signals and electronics. And here I'll talk briefly about the technology and then take a little detour to the fundamentals. How do we understand this coupling? Then I'll talk about some electrophoretic devices for drug delivery. And I'll talk about devices that change shape as a way to decrease the invasiveness of neurosurgery. So a way to frame the discussion on bioelectronics is to consider the two worlds, the living and the electronics, and consider their properties. So if you talk about mechanical properties, here we're talking about mostly soft materials, especially inside the brain. It looks like jello. While electronics in their traditional form are made out of mechanically stiff materials. The communication between two worlds is also very different. Here, the communication between cells, tissues, organs takes place by multitude of signals that range from small metal ions, sodium, potassium, all the way to components of cells like vesicles that contain proteins in their cell membrane. While here, the communication between these two components takes place by exchanging an electron flux, something we understand quantitatively. Biological systems are dynamic, change shape, evolve, change chemistry as a function of time. Electronics are static, borrowed from some recent work on biodegradable electronics. They would spend their lifetime in one form factor. So bioelectronics, in a sense, is an exercise in bridging these differences in properties. Now, the difference in mechanical properties, the difference between hard and soft, has been bridged over the last decade. There has been a lot of work there, making electronics with form factors that are similar to those of biology, by making them, for example, either thin, very thin, so that they become flexible, or made out of materials that are elastic. We can have devices today that can sit on the brain without mechanically loading it. So I would consider that this first bridge crossed. Let's move on to the next one. And the next one is a formidable one. Here we need to teach electronics foreign languages. We need to teach them to communicate with biology and to read out biological signals. So information flowing from biology to electronics to do diagnosis. And in the opposite direction, in order to deliver treatment, we need to be able to stimulate biological processes, actuate them through electronic control. Now, I'll frame this discussion in for the case of epilepsy. which is a condition that affects about 1% of the world population, will experience repeated seizures through their lifetime. And about 30% of epileptic patients are drug resistant. In cases where epilepsy is severe enough to be disabling and it's drug resistant, resection surgery becomes the next treatment of option of treatment, which means electrodes are implanted in the brain to localize the epileptogenic zone, the region of the brain that gives rise to seizures, in order to resect it. So there are a couple of electrode arrays implanted in the brain of this patient, monitoring activity, electrical activity in different brain structures until a seizure is manifested. And then you try to backtrack and figure out which part of the brain gave rise to this seizure so that it can be removed. So the challenge here is to make better electrodes to localize this with as high signal to noise ratio as possible, and to also make the recording less invasive. If you could localize things inside the brain from outside, that would be desirable. So what you want to do is to couple ionic fluxes in the brain, ionic fluxes caused by the chatter of neurons in the cerebrospinal fluid. So we're talking about ions in the liquid environment with electronic carriers inside a solid. If you try to do this exercise, this is an argument we put forward a couple of years ago to explain what type of material we need. And I think it's still current. If you try to do this with silicon, which is the champion electronic material, you run into the issue that you have an oxide or a nitride to protect silicon from the corrosive cerebrospinal fluid. And that spaces away the two carriers and decreases their interaction. Even if you go for a noble metal electrode, platinum, gold, that forms a flat surface without an oxide to the cerebrospinal fluid, you're going to arrive at a situation where you have electronics and ionics on different sides of the opposite sides of the interface, forming an electrical double layer. And the capacitance in this case, which is the quantity that determines the interaction, quantifies the interaction between electronics and ionics, is around 1 to 10 microfarad per square centimeter, regardless of what material you use here, as long as it's flat. So there is a hard limit to how strongly you can couple biology and electronics. You can try to cheat and nanoscale this surface. However, so you increase effective capacitance per unit area. However, there are limitations here in the clinical translation of such materials. Nanoscale materials tend to evolve in biological media. Chunks of it tend to come off the electrode and into the brain, and that makes clinicians very reticent in translating this. An alternative approach is to use materials that allow volumetric conduction of ions. So ions from the electrolyte can be uptaken in the structure of the material and then coupled with electronic charge in the whole volume. One example that we'll talk about today is the commercially available conducting polymer called PSS. We're not going to get into details of chemical structure here, just consider it as a semiconductor that can uptake ionic carriers, and electronic carriers can also move in its volume. So in these cases, you end up having effective capacitances per unit area that largely exceed the double layer limit. And that allows you to make state-of-the-art device, a device with state-of-the-art performance. You can also come up with novel concepts. For example, time reversing this process. You can have the electrode source drugs into the brain by electrical trigger. So again, PSS is a model material for these studies. It has a capacitance that scales linearly with volume. So the thicker you make the film, the higher the capacitance, because you have more volume for electronics and ionics to come together. If you put some numbers, then you can understand the benefit that you get with these coatings. for example, if you have 130 nanometer thick film of P dot, you're going to have an effective capacitance per unit area that is 2 orders of magnitude larger than what you would have in a gold metal electrode. So that means now that you have 2 orders of magnitude better coupling between ionics and electronics. Or it means that you can now make your P dot electrode 2 orders of magnitude smaller and be able to record with the same signal to noise ratio as a 100 times larger electrode made out of gold. So you've just gained in spatial resolution. Taking this argument forward, we made microelectrodes out of this P dot layer. We introduced them into a flexible, very thin plastic platform that is conformal to the brain. And it can conform, shown here on on an orchid leaf, to conform to radii of curvatures that are what you need for applications on the cortex. And being so small, they were able to record single neuron activity, something that was thought to be impossible a couple of years later. Again, these are very weak signals that require very high signal to noise ratio electrodes in order to pick up. So this was deemed to be significant enough to translate in the clinic in an expedited process. So these are now used by several hospitals. I think it's up to 20 now in the US, to record from the human brain. And they record both what are called local field potentials, which is the average, spatiotemporally average activity of many neurons, but also in the proximity of the electrodes, but also record the spikes, which correspond to single neuron chatter just underneath the electrode. So this is the highest resolution brain recording technique from the cortex. And it has the advantage that it can record neurons without disturbing their environment. Now, this was a couple of years ago. Current work now in my group involves making those larger area and higher density. We're trying to oversample by going to a very small pitch and be able to record a single neuron from multiple electrodes, so we can play then localization tricks that you would do with penetrating probes. And also making them optically and MRI transparent. This is largely done. We have electrodes that are made out of P dot that can record single neuron activity, and at the same time allow some very high quality imaging through them without disturbing the electrical signal. Now, how do they really work? Let me spend a couple of slides for those on this. And this is for those of you who are aficionados of fundamental research. So an electrode in an electrolyte usually is discussed in the context of, is it capacitive or is it Faradaic? And Faradaic would mean that it participates in electron transfer reactions with species in the electrolyte. This is language that was developed for metal electrodes. And obviously a Faradaic electrode wouldn't be suitable for brain interfaces because you don't want chemistry happening in the brain. So again, to bring everyone on the same webpage, a capacitive electrode means that you apply a potential between 2 electrodes in an electrolyte. You have an ionic current that is transient and leads to accumulation of ions at the surface of the electrode. This cancels the field in the bulk of the electrolyte, concentrates the fields here. So you form a double layer capacitor here, another one at the back electrode, and the current stops. So these store charge at their surface, and the current is only transient. And if you look at current voltage characteristics via cyclic voltammetry, you tend to see something that looks like a box. A Faradaic electrode, as I mentioned earlier, would exchange electronic charge with the electrode. And as a result, you can sustain a steady state current. So here you transfer charge to the electrode, electronic charge that is, and obtain a steady state current. And on the cyclic voltammogram, you will see characteristic redox peaks, as they're called. Now, this was the ideal case of metal electrodes. What happens if you have a polymer? Then things become complex, and people focus on a CV, on a cyclic voltammogram, where you see mixed behavior. You see a box, but you also see peaks. And if you ask people in the field, what's the interpretation? I think the majority will tell you that, oh, it's both capacitive and Faradaic, or this is called pseudocapacitance, or something else is going on. There's no consensus. And there is even the school of thought that says, no, it's all Faradaic. Even this box-like behavior could be referred to a Faradaic process. The point that I will make today is that looking at CV, cyclic voltammograms, and try to divine the mechanism of operation is a particularly, is an exercise that will not yield fruit. The cyclic voltammogram, as I will discuss later, is the outcome, reflects the outcome of many processes taking place. And as a result, you cannot figure out which one is limiting your current voltage characteristics. But people also do impedance spectroscopy. There is a variety of models that have been used to explain the properties of conducting polymers. And everybody seems to have their favorite model. And those often contain nonlinear elements, such as constant phase element, Warburg elements, that do not have an exact, let's say, connection to reality, to fundamental processes. So they tend to make things a bit more, more opaque. I think it was Dyson Freeman or no, sorry, Freeman Dyson wasn't him. It was Richard Feynman, who said, if you give me a model with 3 parameters, I can fit an elephant. And if it has 4 parameters, then I can make him wiggle his trunk. Anything that complicated is probably not very informative. On a more fundamental level, the mechanism of ion transport in the films is debated, whether it's drift or diffusion, and you know, you can dig deep and not find a good answer. So together with Dave Martin, we looked into P.PSS, made electrodes of different shapes, different sizes, in different electrolytes, different thickness, and made from different methods. And we looked at the structure of these electrodes carefully to quantify their volume. And we could fit all the impedance spectra. These are just some representative curves, and they were normalized so that they convey the physics of this model, which is basically, we're saying that it's a resistor in series with a capacitor, the capacitor being the electrode, the resistor being the communication with the electrolyte. As simple model as you can get, and all these curves would fall on that model. So it's a very, very simple case. And if you look into the data, the capacitance is proportional to the volume of the electrode, as I mentioned earlier. Here, a more complete data set expanded for different conditions of depositing the P-dot, while the resistor scales with the area of the perimeter of the electrode. And this scaling was inferred many years ago. Any electrode that you put in an electrolyte, the electric field will be predominant around its perimeter. And that's what this model conveys. So a textbook example of a capacitive response. If you had to describe a capacitive 3D volumetric conducting electrode, that would be, these were the data that you would show. And this begs the question, is this the exception or the rule? So in my view, to answer this question, we have to go back to the physics of OLEDs. And to remind you, these are devices that are used in displays, in cell phones, and in a lot of TVs. And they consist of an organic stack that is described by the highest occupied, this for a single layer device, but similar arguments for multi-layer devices hold. So you have the highest occupied and lowest unoccupied molecular orbitals of the organic. You have the Fermi levels of the anode and the cathode electrodes that inject electrons and holes into the organic semiconductor. This drift towards the opposite side, recombine, leading to light emission. So this 1, 2, 3 are the fundamental processes that take place in order to make the phenomenon of electroluminescence happen. And if you just look at the current that takes that goes through this device, there's no way to divine whether electron injection, hole injection, electron transport, hole transport, recombination, which of the fundamental processes is limiting device performance. So when this energy level diagram was put together for the first time, this was early 90s, if I recall correctly, then great progress happened in understanding the device physics and being able to optimize it through simulations and through experiments that, that looked at these fundamental processes one at a time. So this is, for example, a prediction from a model of where recombination will take place within the stack as a function of injection barriers and differences in mobility. So this has been extremely useful for OLEDs. And what I advocate is let's do the same for the process of electrochemical doping. So here, the elementary processes would be injection of an electronic charge from a metal electrode into the polymer, transport of that electronic charge. At the other end, you have injection of an ion from the electrolyte to the polymer, transport of that ion, and then their compensation, their electrostatic compensation. So these would be the basic processes, the fundamental processes that will take place to make a polymer electrochemically doped. Now, you can even build energy level diagrams for this. And the important thing is that these steps are correlated. Which one happens first, which one follows. This is determined by local electric fields and band structures. And only when you start thinking along these lines, then you can start addressing questions of how efficient this process is, where the recombination takes place, this compensation takes place, and answer device level questions that are important to answer. But a conclusion that comes out of this exercise is that doping, as shown here, is a purely capacitive process. We're talking about compensation of charge that will eventually lead to no steady state current flowing through this system. However, there can be Faradaic processes, and in this framework, they are the result of a departure from this ideal picture. For example, in a solution, you would have oxygen. This is the LUMO of oxygen is sitting at about, if I recall correctly, 5.2 electron volts. Very close to the highest occupied molecular orbital manifold of a polymer. And you might have transfer of electrons from the polymer across the electrolyte to the LUMO of oxygen, of molecular oxygen. That would be a Faradaic process. Or you could have a material that cannot be penetrated by ions, either because it's too hydrophobic or it's too dense. In that case, you would accumulate electronic charge at this interface, and you would cause large electric fields that would lead to electrolysis, again, a Faradaic process. So with this framework in mind, we can start constructing energy level diagrams, separating the elementary processes, transferring knowledge from the field of organic electronics in order to understand the device physics of electrochemical doping. and device is the operative word. What I'm trying to pass across is that we need to consider this as a device. So back to brains and bioelectronics. You can obviously tell that I'm very excited when I talk about the fundamentals, but I'm equally excited about this. So if we look into back to epilepsy, so far we've been talking about electrodes that record neural signals by having the property of mixed conduction, where ions can penetrate into the electrode coupled with electronic charges, and that leads to good transduction. Now we're going to look at the opposite process, where we use an electronic device to supply biomolecules into the brain and get it to be either excited or inhibited, to inhibit behavior. And again, this is in the context of treating epilepsy. As I mentioned earlier, anticonvulsants are used as the first line of defense against epilepsy. However, 30% of the patients are drug resistant for reasons that are not understood. And this is since the 50s, when the first anti-epileptic medications were developed. Drugs have also side effects. And in the cases where epilepsy is severe and drug treatment is not working, resective surgery, where the epileptogenic zone is localized and then removed, is the next treatment option. However, that surgery is not always possible. Sometimes the epileptogenic zone is too deep, or it overlaps an area of high functionality, and the cost benefit analysis just doesn't pan out for that patient. So in these cases, we advocate localized delivery into the epileptogenic zone of a drug that will act to calm the seizures. Now, localized delivery carries the advantage that you're past the blood-brain barrier, so all of a sudden you have a much larger gamut of drugs. 98% of the pharmaceuticals that we have developed cannot cross the blood-brain barrier. So now that you're past that gate, you have a much larger gamut. Moreover, you are dosing very locally at small amounts, and you can avoid side effects that come with systemic administration. So you can use drugs that are extremely potent, but would also be toxic if delivered systemically. This is a concept that has been developed for brain tumors after resection, to do localized delivery and kill the remaining cancer cells. And again, a large gamut of drugs, repurposing all drugs, spatiotemporal control are advantages of this process. However, biomaterials or bio device aspects where you use a little gizmo that delivers drug for a little bit of time have limited use, especially in the case of epilepsy, where you want a chronic treatment that turns on when before a seizure arises. Convection enhanced delivery in principle could give that, but as you deliver mostly solvent with a little bit of drug in it, you have issues with reflux of the drug and pressure-induced edemas, as the pressure in the brain is confined by the skull. There are neurological effects that are elicited when you try to pump a large amount of solution in it. So again, new technologies would help here. And we were very excited to see this work from Magnus Berger's group and Agneta Richter-Dalfor's group in Sweden, where they developed devices for delivery by electrophoresis. So here you have two reservoirs. They're bridged with a material that's very similar to the one I talked about earlier, the P.PSS. And you can have transport of ions through this material by applying an electric field. And importantly, here you transport only the drug and not the solvent. So it's dry delivery that doesn't raise the pressure at the target reservoir. So it's particularly suited for applications in the brain. So these utilize an ion exchange membrane, a membrane that has fixed an ionic charge in this case, that separates your reservoir from the brain. And by applying a potential, you can get a cationic drug to move through this membrane and into the brain, while at the same time you block the ions going the other direction because of the Donan exclusion principle. So they allow unipolar, unidirectional flow of ions, and as such you can control the delivery process. This is a device that was made for preclinical studies in rodents. It has a U-shaped microfluidic with holes where the epileptogenic zone would be, and these holes are capped with this ion exchange membrane. So you flow the solution of drug into the brain, you apply a potential between inside and outside of the device, you get the drug to come out, and you return the solvent out of the brain. So here we're sourcing GABA, which is a native neurotransmitter in the brain that represents the brake signal. And by applying only a very small voltage, you can up the concentration of GABA locally quite dramatically and achieve a therapeutic effect. This is shown here, where we can kindle epilepsies in a mouse model. With a device implanted and switched off, you see that the seizure just manifests itself. When it manifests itself, you can turn on the device and make it go away. The spikes that you see here correspond to an electrical artifact as we're puffing the delivery of GABA. And you can also show that you could prevent seizures if you had an early warning from a sensor, where you would turn the device on, you try to kindle the seizure, and the seizure just doesn't appear. And then later, when you stop the device, you can kindle another seizure. That data is shown on the paper. So very exciting results, but of course the translation from the animal to human it's a very long road. One of the former postdocs, Chris Proctor, who championed this work, now has his own position at Cambridge, his own group, and he's leading the translation of this device. We're trying to tune this device for other scenarios, and this is a formidable exercise because there's not one size fits all. You need to, for example, if you want to address brain tumors, you need to be able to dose in centimeter scale voxels, and it wasn't a priori clear that this is doable. So by doing some modeling of devices where we're able to verify the obvious that you cannot tune a device for every scenario, you need to pick your scenario and then tune the device for that. And with the help of that, we were able to make devices that can dose over very large voxels. Suitable here, showing dye in an in vitro model, but current work, we're pumping cisplatinum now in equally large voxels. So this is through an EPSRC funded IRC, which includes Riley Green at Imperial as one of the people who are championing new technologies to deliver chemotherapy in non-resectable tumors. The final point I want to talk about is devices that change shape. I showed you in the beginning my view of bioelectronics. The last property to be bridged was the dynamic versus static property. If you look into neural surgery, you need to place a cortical array, you need to do a fairly large craniotomy, and then slice the dura open, put the array on, close the dura, close the skull. It is brutal. Wouldn't it be nicer if you could have a small burr hole, stick in your electrode array in a folded form, and then deploy it under the dura? Similarly, for spinal cord surgery, to place a paddle electrode, you need a laminectomy, which is a brutal procedure. wouldn't it be nice to be able to place these electrodes through a paddle, through a spinal tap? So looking at the field of soft robotics, we were inspired to make devices that are very flexible, very thin, and carry electronics and fluidics that can be used for actuation. So you can achieve motion such as unrolling in the forward sense or in the lateral sense to deploy a paddle electrode. So we make electrodes that have the same format as a paddle for spinal cord stimulation. We can roll them up, we can unroll them, their impedance doesn't change. And then you can deploy them by fluidic action as shown here in an in vitro model. So these were placed in human cadavers, and again by a burr hole through a 2E needle, and then deployed. These lines that you see are markers depicting the furthest extremes of the device. And this is in the brain through, again, human cadaver, through a burr hole. You can deploy a cortical array over 2 centimeters through a small burr hole and a needle. So this is very promising. We're very excited about this. It's meant to go into animal patients at the vet school. I'd say within a year we should be there. So this is my latest favorite thing. Let me stop here and take questions. So we talked about implantable electronics that hold considerable promise for understanding the brain and addressing its pathologies. I showed you examples of mixed conductors that enable high resolution cortical electrodes that sit on the cortex and do not penetrate the brain. This is an advantage because there is no other technology that can do that. And as a result, it was fast-tracked and it's now in the clinic. I talked about electrophoretic devices that can deliver the drug without the solvent. And as such, they're ideally suited for the brain. We've shown in an animal model that they can stop or prevent a seizure. And we're now, in my group, we're working with those for the delivery of chemotherapy. And Chris Proctor is pursuing the epilepsy work. Microfluidics allow expandable implants that minimize the invasiveness of neurosurgery. This is a first step towards something bigger. We envision that the interface between soft robotics, things that can be actuated in soft materials, and bioelectronics will lead to devices that could, for example, self-implant. You could envision devices that can be implanted through a non-straight trajectory and become much less invasive, devices that can move within the brain as the patient gets older or as the device causes habituation, it moves to another neighborhood. So I think there's a lot of mileage to be extracted from this concept. Let me thank my group. The group is co-led with a very talented young clinician, Damiano Barone. Lots of postdocs. Lots of these names are in collaboration with other groups. Collaborations in Cambridge and in other institutions. Let me thank, I missed Riley here because I didn't show any work. Riley, I'm very sorry. I didn't show any of the work that we do together, but she's someone that I'm super excited to be working with. Thank you very much for the kind invitation, for your attention, and I should also thank the funding agencies who paid for this work. So I'll stop here and take your questions.
Thank you very much, George, for I would say this journey from the fundamental over to devices, bioelectronic devices, and then of course also technological evolution of implanting these devices into animals. So we are open for questions. I'm checking the Q&A. Is there any questions? There's one from Mustafa. Jam Gods.
Hi.
He says hello. And also he asks, what about using bioelectronics directly on tumors, not involving chemotherapy? For example, just applying electric fields.
Absolutely. This is something that we've been talking about. Mustafa, I'm delighted you're in the audience. Absolutely. You have done some pioneering work on this. You are editing the journal that will address this important topic. There are three communities, as you know, that look at this problem. You have the people who look at electroporation as a way to act on tumor cells. Then you have the tumor treating field community that believes that mitosis is affected when you apply 200 kilohertz excitation. And then you have the electrophysiology community that says you can prevent maybe proliferation, maybe even migration by, I'm blanking out, metastasis by applying the appropriate electrophysiological stimuli. What it would be extremely useful to do is to take a unified view and construct a phase diagram where you have intensity versus frequency of excitation and look at what happens in this phase diagram at different phenomena: cell death, proliferation, differentiation, what have you. Whatever you have good biomarkers for, just map it on that area. This is extremely important, and it will help also understand. To me, this is the equivalent of understanding the mechanism of neuromodulation, understanding here in this case what electric fields will do to tumors. So I do think it's exceptionally interesting research direction, and I look forward to talking to you. I'll actually email you today about this topic.
Fantastic. Yeah, thank you very much. Another question from V. Kumar. Is there any limitation in size, considering that the device is flexible and it can be broken, for example, within the brain?
Yes, so I would say the size of the device, and I assume this is the flexible and rolling devices. How would you design this would depend on the treatment scenario. If you are trying to implant a pain stimulator, a paddle electrode that stimulates the spinal cord to alleviate pain, that would go in for the life of the patient. You would have to make sure that it could be explanted in case that something goes wrong, but you would count for it being there for the life of the patient. If you want to deliver stimulation in the spinal cord for the purpose of spinal cord injury, where you try to induce neurons to reconnect across the lesion, in that case, you're looking into temporary use. You would have the device in for a couple of weeks, and then you would explant it. So the design considerations would be rather different. Being able to explant the device is a tricky thing. When you unroll the device and expand it, you need to make sure that it can easily be maybe not rolled back completely, but at least deflated so that it can be removed. So, but this is something that we have seen in other contexts. For example, in cochlear implants, one of the biggest issues is you want to maintain as much function as possible. There's always some residual function. So when you put in the array, you try to elicit the least amount of trauma. That points to making arrays very slippery, so cochlear electrodes. But then if they're slippery, then they're gonna move after implantation, and that's a bad thing. Similarly with these devices, you could think of making them easier to place, but the same property will make them prone to movement. So there are lots of trade-offs, and you would need to consider them for the exact treatment scenario. Having said that, the work that we've done in cadavers and in animal models points to the fact that they do survive the surgery, they remain functional after implantation, and they can be explanted once deflated. It has enough strength, so when you pull it out, it's not gonna leave part of the device inside.
Right, there is another question from Cleo Grieve. Do you have any thoughts on the use of non-invasive vagus nerve stimulator on inflammatory conditions, or more recently mediating the effect of SARS-CoV-2?
Mm-hmm. So this is the original name for, let's say the name that was given to this was electroceuticals or bioelectronic medicine. Initially, it was reserved for trying to act on peripheral nerves to deal with conditions such as autoimmune disorders, inflammation, rheumatoid arthritis. This is very new and very much in the area of research. There are a couple of people who have been implanted with stimulators on vagus nerve by a company called SetPoint Medical, which is out of the Feinstein Institute. I met one of these patients. She suffered from, I'm embarrassed to say that I don't remember if it was Crohn's disease or rheumatoid arthritis that was causing, it was extreme. And with a flick of a switch, again, she regained back her mobility, her freedom, the lifestyle that she wanted. And spectacular results, but very early stage, really early stage research. And that's where I'm gonna leave it. Actually, I can add one more thing. When it comes to stimulating nerves versus the brain, stimulating nerves is much more difficult. In the brain, you have the skull where you can anchor your electronics. I'm talking about preclinical research. In a nerve, anchoring your device and your electronics there is very tricky, slippery little thing, very easy to break. Experimentally much harder to do.
Right, and there's one more question from Shafiq Bustan. He says, yeah, even though neuromodulation electronic devices and technologies are there, why physicians are following traditional method of giving medicine and surgery for epilepsy?
Yeah, because there are a couple of issues. First of all, it's a very, very traditional community. So changing the way things are treated takes a very long time. Second is neuromodulation devices for epilepsy are not very efficient. They cut down seizures by, at best, 2/3. Similarly, for DBS, the example that I showed you, deep brain stimulation for Parkinson's or for tremor, there was still a bit of tremor. The situation improved by quite a lot, but the patient didn't return to what we would call normal, zero tremor. So there are limitations of the devices, the current devices. In certain cases, it's expensive and it's not covered by the insurance. In certain cases, patients do not want to have a device implanted. So there can be many reasons. I would say the number one would be the reticence to change the standard of treatment, together with the cost of the device, making some of these treatments of limited availability.
Yeah. We have time for the very last question from Ji-Sun Kim.
Yeah.
She says, great talk. You showed PSS as a good organic molecule for bioelectronic applications. Are there any other materials developed? What's the key challenge for materials development?
Yes, so the PSS is a very complex material. The reason why lots of people work on it is because it's commercially available and works quite well. There are materials that work already better, that have a simpler structure so that you can understand, you can start doing structure properties, relationships, and all that. But the overarching view on this question goes as follows. So what makes organic electronics and organic bioelectronics and extension fascinating is the fact that you can have infinite chemical structures. The materials are like Legos. Working with a synthetic chemist, you can tune them any way you want and start learning about their properties. And this fascinates people. It's a wonderful degree of freedom for doing science, but it's terrible when you try to commercialize or to translate to the clinic. There you need to pick one horse early on and stick with it. And this is the case with PDOT. We have materials that are better, like an order or 2 orders of magnitude better in terms of transconductance, everything else being the same. But the pain that you have to take to get another material in the clinic is not worth it unless you can show dramatic changes, something that could not be done with the previous technology.
Right. Unfortunately, there is no time for further questions because our time is over. But I'm sure there will be. There are. I can see there are a lot of questions that you maybe can address directly to George. And thank you very much, George, for this great talk. Very inspiring and also very comprehensive. And I'll hand it over to Lee, perhaps, for final remarks.
I just want to say thank you very much again to George and to Felicie for doing this webinar for us. It's been great and informative, and we're really grateful that you guys spent your time to do this for us. Thank you very much.
Thank you.
Thank you. Bye-bye.
Bye, George.
Bye.
Thanks for inviting me. Thank you.